is basically about the diagnostics in glaucoma. So we'll try our best to make it simple for you to learn about the diagnostics. Luckily, we've got our first presenter available here. So I would like to invite Dr. Yusuf Jamal Mashood, who came all the way from Peshawar, to guide us about central corneal thickness. Thank you.
Bismillah ar-Rahman ar-Rahim. My name is Dr. Yusuf Jamal Masood. I'm working as Assistant Professor of Glaucoma in Khyber Girls Medical College, Hyderabad Medical Complex, Peshawar. Today my talk is on central corneal thickness and its relation with glaucoma. So I will just be briefly touching the clinically relevant questions pertaining to the relationship between pachymetry and glaucoma. So what do most of the ophthalmologists know about CCT and IOP? They know, most of the ophthalmologists, they know two things. Number one, they know that the thicker the cornea, the higher the IOP, and vice versa. And there is relation between conversion of ocular hypertension to glaucoma in thin cornea. The second thing, they know the sources of error which occurs in IOP measurement in relation to cornea. But what I will be talking about is there are a few questions that are usually asked by residents and other ophthalmologists. What is the effect of CCT on IOP measurement? Is CCT an important risk factor for a patient developing glaucomatous optic neuropathy? Is it an independent risk factor for progression of glaucoma? Should we be correcting it in our pressure measurement? And how should we use CCT when we are managing patients who are at risk or with glaucoma? So I'll just briefly answer this question. Number one, what is the effect of CCT on IOP measurement? So there have been numerous studies. I will just highlight a few of them. There was a study which was called the Barbados Eye Studies, and they checked what is the distribution of the central corneal thickness and the relationship between CCT and IOP, but that was predominantly in black population. So what were their results? Their results were that they recruited more than 1,000 patients and did the pachymetry measurements. The mean age was 64 years, 58% were women, and they found that the black participants, they have thinner corneas as compared to white or mixed races. So their conclusion was that although other studies have reported a positive correlation between CCT and IOP, but they did not find any such correlation in black patients. And they found another important finding, that black participants, they have thinner corneas as compared to the white participants. But there was another study. What they did, they checked the effect of central corneal thickness, corneal curvature, and axial length on the applanation tonometry. That was a prospective clinical trial, and that was a masked trial. So they recruited those patients who were booked for cataract surgery. They did this CCT and the IOP measurement with the applanation tonometer, and before creating just when they were creating the incision for cataract surgery, they cannulated the anterior chamber and they checked the IOP measurement with manometry. So what were their results? Their results were quite significant that there was actual difference between measured and real IOP, and they were really dependent on the central corneal thickness. And there was 1 millimeter of murky correction for every 25 microns deviation from CCT of 550 micrometer. So their conclusions were that CCT significantly affects the IOP readings obtained by applanation tonometry. And a correlation of IOP readings by considering CCT according to the correlation table might be helpful for determining accurate value. But we will see in later slide that might not be possible, because there is no such correction factor which is universal to everything. Second question, is CCT an important risk factor for patient developing glaucomatous optic neuropathy? So again, there was a landmark trial which is called the OAT study, or ocular hypertension treatment study. There were different objectives, but one of the objectives were that they actually recruited the patient with ocular hypertension, and they divided it into two groups and checked which one progressed to glaucoma. One was the treatment arm, one was the observation arm. But they also identified the clinical factors that might predict which patient will develop primary open angle glaucoma. And their results were, there were different results, but when that were their stratification was done for the corneal thickness, they found that the thinner corneas having less than 555 microns thickness, they have a hazard ratio of 3.4 for developing of primary open angle glaucoma. And for every 40 microns thinner of CCT, the hazard ratio of developing glaucoma was 1.88. So they gave a few predictive factors, that what are those predictive factors which can lead to development of primary open angle glaucoma in ocular hypertension patient. So among all them, the CCT was one of the most important factor with hazard ratio of 1.71. So the bottom line of the old study was that it showed an increased risk of developing primary open angle glaucoma with thinner CCT. Third question, is CCT an independent risk factor for progression of glaucoma? So this question was answered by early manifest glaucoma trial and another trial from Canada. And this early manifest EMGT, that was a study designed to assess the factors for progression of early glaucoma cases, including the effect of treatment. And there were patients that were diagnosed with early primary open angle glaucoma, and they were randomized to treatment versus observation. And these patients were followed for about 6 years. Overall, 53% of the patients, they progressed. And the factors with progression were higher initial IOP, pseudoexfoliation, and initial high mean deviation and older age. Treatment reduced the risk of progression into half, and the average reduction from baseline IOP was 25% in the treated group. Their results showed that CCT was, although investigated as a risk factor for progression, but there was no increased risk that was found in this study. Then there is another study conducted in Canada, Halifax, Canada, and what they did, it was a longitudinal study, and they were examining the visual field and optic disc changes. At that time, they used the HRT in patients with treated primary open angle glaucoma. All patients, they had glaucoma in addition to the visual field defects with a mean deviation between -2 and -10 decibels. The patients were examined with HRT and visual field every 6 months. And patients were all treated, and the treatment was adjusted at the discretion of the treating ophthalmologist, and CCT was measured at the end of the study. So the sample contained 101 eyes. The mean follow-up was 9.2 years. Overall, the thinner CCT was correlated with worse visual field scores at presentation, but CCT was not correlated with severity of optic disc progression on the HRT or the amount of visual field progression. In summary, in established glaucoma, there was no correlation between CCT and amount of progression of glaucoma on either disc or visual field. The patient in this study were watched closely, and therapy was adjusted if progression was observed. Those with thinner CCT, they were more likely to have more advanced glaucoma and diagnosis. So this was one of the major findings in this study, that those who have thinner corneas, they had more worse glaucoma at the time of presentation. So what are the lessons learned? Is CCT an important risk factor for developing of glaucomatous optic neuropathy? Yes, the OATS study clearly showed that. Is CCT an independent risk factor for progression of glaucoma? So these were two different studies, EMGT and Halifax. According to them, it does not appear to be. But the major risk is that there is underestimation of IOP in thinner CCT, and therefore the undertreatment may lead to worsening of glaucoma. Should we be correcting CCT in our daily routine measurement? Since there is no universally accepted table, so adjusting of IOP is difficult. In the next talk, we will see how corneal hysteresis has helped us in these studies, because there is difference. If there is more than 100 microns of difference between CCT, there is 2 to 6 millimeter of mercury difference when you are actually correcting the recorded IOP and the actual IOP. So how should we be using CCT? So as a part of initial investigation, it should be done, but in follow-ups, since the target IOP is a dynamic factor, we should be using the target IOP according to the progression of the glaucoma. So again, the take-home message is this, that the patient with thinner CCT, they have late diagnosis maybe because of undertreatment, and it is an important risk factor. What are the challenges? More work on the universal conversion of factor for IOP, and I think here the corneal hysteresis, it has its own role, and that we will learn in the next presentations. Thank you, everyone. Any questions?
Thank you, Yusuf. Thank you for a nice presentation. We will try to hold the questions for the end because we are a bit tight in terms of time frame. So I would like to invite Dr. Manaz Shah for her talk on corneal hysteresis. And these are something maybe slightly correlated, and we can have a detailed question answer session at the end. Thank you so much for coming all the way from Karachi.
Bismillahirrahmanirrahim, and thank you for having me here this morning. So my talk is going to be on corneal hysteresis with the Aura G3, which is a device that we have been using for the last 3 years now. And this has, of course, been available worldwide for almost over a decade now. And I want you to just go along with me for the next 10 minutes to see how this is going to be useful. So corneal hysteresis is actually a measure of the viscoelastic damping ability of the cornea. And this is the cornea's ability to both absorb and dissipate energy. A low corneal hysteresis value, and the corneal hysteresis is again measured in millimeters of mercury, is associated with a greater degree of progressive glaucomatous optic neuropathy, as well as an enhanced degree of visual field damage at the same pressure for two individuals who may have different corneal hysteresis values. How do we measure corneal hysteresis? Well, corneal hysteresis is measured by a device that is shown in the center image. This is just a tabletop device. It's very easy to operate, very portable, and the patient is seated just as if they were getting an air puff tonometry done. But here, the air puff that is used to create a pressure curve is actually not used to just generate a pressure value. It's actually used to generate a measure of the viscoelastic damping ability of the cornea. And what happens is that if you can see on the image on the right, you can see a central probe. That's where the air jet comes around. And then you can actually see the two little infrared detectors. So you can see the image on the extreme left where there's an air puff jet that's going to come inside. The cornea is going to flatten with this air puff jet, and then as a result of that flattening, both or when the cornea is going inwards, there's one flattening that occurs at that point in time, and then again when the pressure decreases, the cornea will flatten on its way out, and that's going to be the second point at which these two infrared detectors are going to be able to pick up where this flattening has taken place. This is essentially the curve that's generated by the machine. So the green curve that you see here is basically the pressure. That's the air jet. The pressure rises, reaches a maximal point, and then comes down again. And the red curve over here, or the two peaks that you see, are the in-signal peak, which means that the infrared detector is going to pick up the first peak where the cornea flattens on its way in with the air jet, and the second one is when it flattens on the way out again. And these two peaks, if you take them down and intersect the green curve, will give you two pressure readings. And the difference between these two pressure readings is corneal hysteresis. So this corneal hysteresis value, if the cornea has been able to absorb a great deal of energy, the corneal hysteresis value is going to be, wider, right? It's going to be larger because it's got a greater degree of millimeter difference. However, if there's very little absorption that's occurring, the value is going to be the difference between the P1 and P2, these two peaks that you can see as the applanation pressure 1 and the applanation pressure 2 readings is going to be decreased. So your corneal hysteresis value is also going to be decreased. And as I said earlier, the corneal hysteresis is measured in millimeters of mercury. So the cornea has elasticity, it has viscosity, and it absorbs energy during this bidirectional applanation. corneal biomechanics can be used as a surrogate for globe biomechanics. And this suggests that the data is very clear on this, that if you have a low corneal hysteresis value, the damping ability of the cornea, the shock absorbing ability of the coatings of the eye is decreased. So pressure variations and elevations of pressure seem to be more damaging to the lamina cribrosa as well as to the optic nerve head. This is the reading that you actually get on the machine. You get a right and left reading. You can have it to where you get 3 consecutive readings and you average out from there, or you can do a single reading. Even if you do 3 readings, it takes really less than a minute to do this per eye. And you can see the values of IOP-CC, and this is IOP corneal corrected value. So that's where the corneal hysteresis has been taken into account. Then you see the CH, which is a corneal hysteresis value. Here it's 11.5. This is normal for a patient. And then you can see an IOPG, which is like the Goldman equivalent of 16.5. And there's a very high degree of accuracy between what the machine will tell you using this particular technology versus what you would do as a good operator using your Goldman. And in fact, and there are glaucoma clinics in the United States which now use solely the Aura to do much of their pressure reading. And this can be for patients who are post-op, or early post-op, or after a significant period of time, or those who have not had any other surgical procedure done. So I want to show you a clinical application here. This is a 54-year-old male with normal presenting intraocular pressure. The axial length was longer, 27.3 in the right eye and 26.67 in the left eye. Corneal thickness is decreased, and the cup to disc is 0.9, and the patient's on maximum medications and is compliant. And yet, despite an intraocular pressure that ranged every single time between 11 and 13, the patient was showing progression and had a trabeculectomy. The pressure stabilized out, and the optic nerve head stabilized out. Retinal nerve fiber layer was also then stable. And if you look at the image on the right, you can see that the corneal corrected intraocular pressure is 12.4 and 12.4. But if you look at the corneal hysteresis value, it's 8.9 in the right eye, 9.2. And interestingly, this was the right eye, even at that value, that had a greater degree of damage that was existent. So I'll just show you a couple of very quick cases. This is a 70-year-old gentleman in 2007 who had an intraocular pressure of 28, normal corneal thickness, and was followed for a cup to disc of 0.7. Corneal hysteresis was not available at the time. But 5 years later, the patient had been on 3 topical medications. His intraocular pressure was still 24, and there's no progression in 5 years. And when we looked at the corneal hysteresis value was 13, which is higher than average and higher than normal, which is protective for this patient. And this patient can be considered low risk. And so there's no reason, even at a pressure of 24 on 3 medications, to actually, go ahead and proceed with any additional treatment, any surgical treatment. And in fact, you can try to reduce the pressure-lowering medication. This is a 59-year-old lady who presented in 2016 at an outside facility. Her pressure was 21, again, normal corneal thickness, and the cup to disc of 0.8, and corneal hysteresis was not available at the time, and she had no major risk factors for progression. But in 2017, she was showing significant progression. And again, when her corneal hysteresis value was calculated, it was 6.8, very low. So this is a person who definitely requires further intervention, further surgery. This is the Diagnostic Innovations in Glaucoma study, which shows us on the curve, on the graph on the left, that if you have a corneal hysteresis value of less than 10, you have these fast progressors. But if you have a corneal hysteresis value greater than 10, you really don't have these fast progressors. So when you read a corneal hysteresis value and it's 9.5, 8.8, these are really high-risk patients that you need to follow. And interestingly, in this study, this was a multivariate model, and you looked, many factors were looked at, and it shows that corneal hysteresis is fairly predictive of progression. And in fact, for every 1 millimeter decrease in corneal hysteresis, this was associated with a 0.25% risk per year of increase in visual field decline. The relationship between corneal hysteresis and IOP is complex, and it is also seen that patients who have lower corneal hysteresis will have a greater degree of damage. There is a predictive role of corneal hysteresis in conversion to glaucoma in pre-parametric glaucoma suspects. And you can see on the graph on the left that there is a lower than average corneal hysteresis highs with higher progression, and on the graph on the right, higher corneal hysteresis with lower degrees of progression. And each 1 millimeter lower corneal hysteresis value was associated with an increase of 21% in the risk of developing glaucoma from pre-parametric glaucoma during follow-up in this particular study. Corneal hysteresis is also predictive of the response to glaucoma treatment. So it seems like those individuals who have a low corneal hysteresis value appear to be more responsive to treatment versus those who have a high corneal hysteresis value, because it seems to be that the eye already is compensating and doing what it can maximally do. So if you look at patients who who are put on prostaglandin analogs, those with a low corneal hysteresis value circled in the first quartile of corneal hysteresis with 7.0 show minus to 29% change versus those in the fourth quartile of corneal hysteresis, which show only a minus 7.8% change. Corneal hysteresis is very valuable in patients who are post-LASIK. This is a patient who came in complaining of vision on Goldman. The pressure was 15, but on examination with the Aura device, this was 46 with actually fluid in the interface. Again, this is a situation where corneal hysteresis is a very superior indicator of intraocular pressure, because you will also get a corneal corrected intraocular pressure value. And sometimes these two values can be in opposition. So here you've got a situation where the corneal thickness for this patient is higher than normal. And in fact, if you actually correct for this and look at the corneal hysteresis value, this corneal hysteresis value was fairly low and the patient was showing progression. This particular slide shows us that if you have a high corneal hysteresis value, which is on the x-axis, and if you actually have intraocular pressure, which is on the y-axis, if you have a high corneal hysteresis value and a high intraocular pressure, you are still at a lower risk, high risk calculated as the red section. But if you have low corneal hysteresis, but a moderate pressure, this is still more damaging. So it really helps to actually establish that this is not a static value, this is a biomechanical property of the eye. It normalizes also after intraocular pressure reduction. So the important thing is, if you do an intervention like surgery or anything else, you should reestablish your corneal hysteresis baseline for that patient. And it allows us to be able to apportion our diagnostic and our clinical resources to those patients who actually really need them. So I think this is an important value to keep in consideration and a very useful one indeed. Thank you.
Thank you so much, Dr. Manaz. I'm sure that for many people around here, it would be a new topic for them to learn about. Thank you so much for this. I would like to now invite Professor Syed Imtiaz Ali to speak about fundamentals of gonioscopy.
Bismillah ar-Rahman ar-Rahim. That's my introduction. You see, my talk is very, very basic, and I have delivered this talk for, I think, maybe more than 20 times. But as I always say, that this is a forgotten art, and I want to revisit it. And it's still very useful in presence of all the gadgets that we have. Is the key to diagnosis, to the treatment of any form of glaucoma. Problems of gonioscopy in developing countries, that there is lack of equipment, the lenses are very expensive, lack of awareness, lack of training, motivation, and standard operating procedures, and difficult learning curve. Definitely there is. So the purpose of this talk is the purpose of gonioscopy, principles, method of gonioscopy, angle structures, grading of angle width and developmental anomalies, and then the key points. Why do I need to perform gonioscopy? It's a fundamental part of any comprehensive examination, particularly in a glaucoma case. Most important factor in correct diagnosis, omission may lead to misdiagnosis, done initially for all glaucoma patients and suspects, repeated periodically in angle closure glaucoma more than others. Differentiates between occludable angle and secondary glaucomas. So these are the different classifications that we use, but most of the time we use the Schaeffer's grading of the angle. So if you use the Schaeffer, this is the simplest method you can use. Grade 0 is closed, grade 4 is 40 degrees or open. These are the different lenses that you can use, whatever you can get your hands on and whatever you are comfortable with, or a simple 3-mirror, which is a lens which is present in every clinic, can be used, or you can use specialized lenses. This is a Goldman Style 1 mirror lens. This is a MagnaView gonio lens. You can use a Posner. You can do a rich trabeculoplasty lens. There are two methods, direct and indirect. And indirect gonioscopy can be without indentation and with indentation. The indentation will open up the angle for you. The advantages of direct are straight on view, angle of visualization is variable, more panoramic, angle recession comparison can be done. Disadvantages, it is inconvenient, needs special equipment and a very expensive lens. This is the most commonest lens that you can use. Every clinic has it. You should align the outer canthus with the black mark on the slit lamp. This is the lens that Zeiss lens you can use. It can be, doesn't need a coupling fluid. You do the proper magnification, at least 10, and explain to the patient what you're doing. This is our optometrist in the clinic. And then have a good elbow rest so you are comfortable because you're going to be there for 2 minutes. And general guideline, first do the external examination. Tonometry must be done before gonio. Use local anesthesia. Pay attention to the comfort of the patient. Fairly short and narrow beam, 2 to 3 millimeters. Use a semi-dark room. And pupillary constriction makes a narrow angle appear more open. Tell patients what you're doing. Use low lighting, avoid light entering the pupil, more physiological, more likely to see apposition, can confirm using indentation, and you can use high magnification as well. And this is the most commonly used 3-mirror. Everywhere it is available, and you use a coupling fluid with it, and then apply as you do in a retinal examination, and keep rotating the lens, and this is what you're going to see. Keep rotating the lens. And this is the normal angle structures. You can start from here, ciliary body, scleral spur, pigmented trabecular meshwork, non-pigmented, and Schwab's line. And then angle structures, and in trabecular meshwork, you must be able to recognize the pigmented and non-pigmented. There's more pigment inferiorly, particularly in our dark races. And Schwab's line will mark the termination of decimus membrane. If it is pigmented, it will be called Sempolisis line. Now this is a diagrammatic representation of what I have been saying. That is the iris, that is the ciliary body. This is the ciliary body face. The white is the scleral spur. Then you will see the pigmented trabecular meshwork that I talked about. And this is the non-pigmented trabecular meshwork, and that is the Schwab's line there. That is the Schwab's line, and that is the cone that you see, corneal wedge. So, an occludable angle is an angle where the pigmented trabecular meshwork is not visible for 1/3 of the circumference. That is when you classify it that way. This is a normal pigmented angle in a video. In our population, colored population, pupil, iris, same diagrammatic representation, ciliary body face, scleral spur, whitish, trabecular meshwork, pigmented, then non-pigmented and maybe a Sempolisi line, and cornea and a corneal wedge. This is another video showing the inferior portion, same. You have to do it repeatedly to learn it and master it. It took me years and months to do it. Then, if you see angle blood vessels, now they can be normal, radial orientation, thick, non-branching, do not cross the scleral spur. Neovascularization will be fine, arborizing, and it will cross the scleral spur. These are the neovascular glaucoma, and you can see in the angle there is a streak of blood vessels there in the neovascular glaucoma. Indentation gonioscopy must be done, useful when the iris surface is convex, done with recognition of angle structures is difficult, performed in all glaucoma patients. Differentiate appositional versus synechial closure. Measures extent of angle closure, identifies plateau iris configuration and identifies pseudo plateau configuration and identifies lens-induced angle closure as well. So you can see this is a metallic foreign body embedded and was detected on gonioscopy there. You can see the rust around it. And what are the key points of this talk? This is a fundamental part of ophthalmic evaluation. Confirmation of normal angle structure, determination of narrowness of closure of the anterior chamber angle, grading of the angle width can be done, pathological findings needs to be performed routinely. And nowadays, you don't need to touch the eye with a gonioscope. This is the instrument by NIDEC, and you can, without touching the patient, you can do the gonioscopy in most of the cases. And it gives you different pictures on the, and analyzes the whole video, and then you can get a good guess if the patient is uncooperative. It takes different 17 frames in 1 second, and then you can see the whole of the angle. Now, this is one of the most important slides after this talk. There was a study done, and it concluded that the study highlighted ophthalmology trainees' dissatisfaction in the current gonioscopy training curriculum and lack of confidence in performing the procedure. Appropriate modifications to the ophthalmology specialty training program could enhance trainees for gonioscopic learning experience. And I would, Rashid Zia is sitting here, I would emphasize upon them that in addition to trabeculectomy, I think they should also run a course on gonioscopy for the sake of juniors. And sometimes even at this stage, I find very difficult to jot my findings down and I get confused. Thank you very much.
Thank you so much, Professor Imtiaz. We'll stick with questions at the end, if that's okay, because we are still very tight in terms of the time frame. So I would like to invite Professor Nadeem Hafiz Butt for his talk about visual fields in glaucoma.
Bismillah ar-Rahman Rahim. Assalamu alaikum and good morning, everybody. Thank you very much, our dear organizers and Chairman Scientific, for giving us the opportunity on the platform of PGA that we are making these presentations and trying to improve the understanding of the subjects amongst the ophthalmologists. And at the same time, from the platform of PGA, we are also working for the public awareness of glaucoma through our social media, through electronic media and print media. In next couple of months, we'll be having the World Glaucoma Week in the month of March, and the whole country then practices the celebration of that, and also creates awareness amongst the public. So this was my workplace previously, currently, and glaucoma is a group of disorders characterized by a typical glaucomatous optic neuropathy, which is clinically manifested by characteristic visual field changes with normal or raised intraocular pressure. You all know that the definition of glaucoma is an ever-changing phenomena, and every few years we see new definition or new dimension in the definition of glaucoma. My focus will be obviously today is on visual fields, and visual fields in general term is also called as perimetry. This is an attempt to assess the visual threshold at a particular location in the visual field. And what is a visual threshold? Visual threshold is a minimum level of light that can be perceived at a given location in the visual field, and is also called as retinal sensitivity. The visual threshold is variable from place to place in the retinal areas, and it is highest in the fovea and decreases towards the periphery, and superiorly it's 60 degrees and is limited to 60 degrees because of the brow. Nasally it is limited to 60 degrees because of the nasal bridge. Inferiorly is limited to 75 degrees because of the malar bone, and temporally it is wider, it is 100 degrees because there is nothing to obstruct on the temporal side. So on the temporal side we see the visual field is more in comparison to the rest of the three areas. And you can see this is a hill of vision, and the maximum is at the fovea, and as you move towards the periphery, this pointer is not working anymore. You move towards the periphery, it decreases, as I've already shown you in the form of the figures. So perimetry is basically of two types. One is the kinetic and the other is static. The kinetic is mostly manual. We used to do it in the form of Gerron screen or Goldman perimeter partly, and a visual stimulus of known size and intensity is brought from the periphery towards the center, and where it is not expected to be perceived, and at some point it will move into an area where it will be perceived, and that is the visual threshold in that area. Whereas the static automated presents visual stimulus in varying sizes and intensities at fixed locations. That is why it is called as static. Kinetic, since the target moves, it is called as kinetic. In this static, the target remains at the same place, whereas the threshold is changed. So higher intensity stimuli are presented, and then gradually the intensity is lowered until the patient can no longer perceive the stimulus, and this will be called as visual threshold in that area. And this is the comparison of the two, kinetic and the static. And in the kinetic, you can see the length and breadth of the visual field and visual scotoma, whereas in the static, you can also analyze the depth of the scotoma or visual field defect. Instead, remember, the kinetic is only the length and breadth, whereas in the static, in addition to the length and breadth, you also assess the depth of the scotoma or the visual field defect. So Humphrey field analyzer is an example of static perimetry, and you can see that different areas show different grayscale, and you can see from the grayscale you can evaluate or assess generally the depth of the scotoma or the intensity of the visual field defect. So as we go towards the darker side, there is increase in the depth of the scotoma or increase in the visual field defect. So lighter the area, more will be healthy in comparison to the darker area. So you can see different shades of gray on this picture, where from the lighter tone to the darkest tone, the visual field defect gives its shape and for morphology, and with the help of this morphology and shape, you can identify the area of the nerve fiber layer defect or damage that has already happened to the patient. There are different types of visual field defects, especially in glaucoma, and we have to remember them, and we also have to recognize them when we see the report of the patient, and then correlate it clinically with the findings that we see on the clinical examination of the patient. The list is quite comprehensive. It covers almost all types of visual field defects in glaucoma: generalized reduction in sensitivity, temporal wedge, nasal step, paracentral scotoma, arcuate scotoma, then the double arcuate scotoma, bearing of the blind spot, total loss of visual field except central 5 to 10 degrees or temporal island, and finally the total loss of field and total loss of vision. So this is to be remembered, but we all have to work very hard with our patients not to make them proceed towards all these, and finally they lose their vision and the visual field. So the responsibility of the ophthalmologist is to that whenever and wherever the patient is presented and whatever is the stage of the disease, we try to stop the disease process with the help of treatment, medical, laser or surgical, and try to save the visual field and also the vision of the patient. So the relationship of the lesion and the visual field, you know that there are arcuate bundles in the form of they arch over the macular area, and they finally end up in the optic nerve head. And the nasal fibers approach straight, whereas the temporal fibers, they arch over the superior and inferior portions of the macula, and you can see these fibers arching over it. And so the pattern of the visual field defects is always similar to the anatomy of the nerve fiber layers. So you have to remember the anatomy, and then you can correlate with these visual field defects. So now these are the few pictures to make you understand that clinical correlation is very important. Now we have to correlate three things. One is the clinical findings, second is the visual field, and third is the OCT findings. So all of them should correlate to find out the exact picture of the patient, how much damage that patient has already suffered. So again, another picture where you can see the superior nasal step defect here, and similar findings on the visual field and similar changes in the optic disc area in the clinical examination. Advanced superior nasal step defect, you can see the changes in the clinical changes and the same pattern of changes in the visual field area. Total loss of field of vision with preservation of central tunnel, you can see there is advanced cupping and changes in the clinical findings, and similarly the visual fields also correlate with the clinical findings. So the clinical indications of perimetry are for the purpose of diagnosis if we find raised intraocular pressure in a patient, or the suspicious optic disc changes, or their patients have history of myopia, or there is a family history of glaucoma. And we also need it for the monitoring of glaucoma for the to see whether the patient is progressing or not, and in the management. So this is the printout of Humphrey Field. Most of you must have seen all these printouts, and you know all how to interpret it. But generally speaking, we first have to see this data on the top. And we have to see the reliability indices after checking the patient's data, the patient's age, since the changes are age matched or age related changes, therefore the accurate entry of the ages is very important. Similarly, we see the reliability indices, and then we see the global indices, which are on the right hand side on the lower part of the report. These are on the left hand side of the upper part of the report. So you also see the grayscale, but important things are the total pattern deviation plots and total deviation plots, and mean deviation you have to calculate. So these reports, and you can see these are the fixation losses, which are the reliability indices, and these are the global indices here on this side. And you see the numerical scale, and then you see the deviation from the normal scale from the total deviation plots, and then pattern deviation plots show those changes that are excluded from the report in the form of refractive errors, in the form of media opacities, and the pupil size. So these three things are excluded, and then we find the report as pattern deviation report. So the conclusion is that the diagnosis of glaucoma requires, if not high, at least an optimum index of suspicion to see the disc with the preview that you have to find and diagnose these patients. And patients of almost all levels of visual field defects and visual acuity can undergo visual field testing. And whereas a careful selection of patients for perimetry is important because it is time intensive and cost intensive, and monitoring of glaucoma can only be done by repeated optic disc evaluations and regular visual field examinations. I thank you for your presence and attention. Thank you very much.
Thank you so much, Professor Nadeem Hafizbad. I would now like to welcome Professor Kareem Damji to enlighten us about UBM.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. Thank you, Dr. Meher, our president, the Pakistan Glaucoma Association, for organizing this and inviting me to speak. So I'll be speaking about a technology that I think is useful in some instances, and I'd like to show you the value proposition. I don't have any particular financial interest in the technology, but I hope by the end of this that it will give you an idea about how UBM can be utilized to help determine the mechanism or mechanisms of low pressure, high pressure. If there's a few minutes, I'll show you some interesting superficial pathology, which is also imaged, and then also ciliary body pathology. And we have a diagnostic service at AKU, and I'll just show you at the end how you can access that. Now, this technology was invented in the early 1990s at the University of Toronto by Dr. Charles Pavlin and Stuart Foster. I was fortunate to go there and do some training with them, and then we acquired it in Ottawa a few years later. So it's almost 30 years we've been using it in Canada. And the principles are that it's high frequency. So most of the probes are a minimum of 25 megahertz. The usual B scan is about 8 to 10 megahertz. Now we're using 35 megahertz, 50 megahertz, and for research purposes, even higher frequency. So you get pretty good resolution. But the problem is the depth of penetration. So it can image the anterior segment fairly well, but not further back. And then you, of course, can, the technology allows you to do some standard measurements as well, which is very helpful. So I think the value, if you just remember this particular slide, is that it is sound waves. So it goes through opaque cornea, through the iris, and that's the beauty, I think, is that you can see tissues behind cloudy corneas, behind the iris, such as the ciliary body, the zonules. You can see the entire lens configuration. Anterior segment OCT can be helpful, but it's light and it will not penetrate all those areas. So what I'm going to focus on today is post-trauma, and then show you some interesting other pathology. So this is a patient who was 20 years old, was driving a car, and in Canada we have airbags in all the vehicles, and the airbag exploded. And this was many years ago, a young patient, and he had a hyphema, corneal edema, and he had pressures of around 15. Now, a few weeks later, the hyphema resolved, but his pressure was 0. So why is his pressure 0? Well, first of all, you can see with the UBM that there's some interesting angle recession that is visualized, right? The arrows show you some attached uveal tissue, but the angle is severely recessed. But more importantly, there are a few clock hours of a cyclodialysis cleft. So the entire uveal structure is actually disinserted from the sclera, creating a continuous flow from anterior chamber into the suprachoroidal space. So now what we did is we repaired this and his pressure improved. Okay, so I think it was helpful to image this because it was very hard to see by gonioscopy given the cloudy cornea. Here's another case of a 19-year-old male who had corneal infection. This was a case referred recently in our UBM clinic, and he had undergone a transplant for corneal ulcers in his right eye. Now, unfortunately, he had a cricket ball injury recently, ruptured the eye, which was sutured nasally. Post-operatively, he had a lot of pain, discomfort, and he was sent to the UBM clinic. And his vision was hand motions. Pressure was about 10 millimeters on multiple drops, but the pressure was elevated. This is the external appearance, and you can see by the slit lamp that there's a lot of flare and difficulty seeing structures inside the eye. There's a white plaque back here, so we weren't sure what that was. Now, with the UBM, you can actually see this is a horizontal axial image. A lot of peripheral anterior synechia here on the temporal side. On the nasal side, so on the nasal side, you can see some corneal folds. There's a lot of particles in the anterior chamber that are very large. We could not appreciate them because of the edema, but very large particles. The anterior lens looks somewhat disrupted, and I'll come to that in a minute. But the lens thickness is reduced, right? So there's some issues with and there's some echolucent areas in the lens. You can see some membranes on the right-hand picture coming from the vitreous to the cornea. And then another view inferiorly shows the actual rupture of the anterior lens capsule. So you can see that it's not formed, that it's ruptured, and there's a reaction around that area. On the right-hand side, you can see the rupture actually extends into the vitreous with a lot of cellular and membranous material. So essentially, this is a case of, probably phacoantigenic, maybe phacolytic component, but it's a mixed mechanism with angle closure as well. And so that's the reason, and the patient, needs the lens removed material to avoid this antigenic response. Here's an interesting case where the patient had Sturge-Weber syndrome, a 6-year-old boy, and he started to develop in the last year or two conjunctival swelling nasally, only nasally. And it was interesting with the UBM, you could see some swelling of the temporal or the nasal cornea, thicker than average, but also you see those bubbles under the conjunctiva. So I'm not sure what this is, but it's not extending from inside the eye, it's just superficial, and maybe it's a variant of conjunctival lymphangiectasia or some other conjunctival chemotic disorder. This was a tumor that was sent to us. You can see some sentinel vessels, and we're wondering how deep does this penetrate. With OCT on the top image, you can see that you can actually not visualize how far it goes, but with UBM on the bottom portion, you can actually see that it does not penetrate into the eye. It does involve some scleral layers. And on the right-hand side, so the left-hand side is actually a radial scan, and the right-hand side is a transverse scan showing the ciliary processes. And you can see there's no direct continuity of the lesion with the ciliary body. So that's helpful to rule out deeper invasion if you have some tumors or other things. Now, let's say you have a patient who has had an iridotomy or lensectomy, and now they still have narrow angles, and you're wondering what the mechanism is, and you do gonioscopy, and maybe the mechanism you're thinking is plateau or pseudoplateau, because when you indent, there is a sine wave or a sigma sign. So here you can see on the left-hand panel that the ciliary body is quite anterior, and there's a configuration that probably fits with plateau iris. On the right-hand side, kind of a pseudo-plateau with iridociliary sulcus cysts. And in this particular case, actually an iris tumor that is closing the angle. And in some cases, it may actually be in the ciliary body. So this is a transverse view of the ciliary body showing involvement there, and a fairly large lesion as well. So we have this service available. We generate a report. On the right-hand side, an example of what the report looks like. This was actually a young child with a variant of anterior segment dysgenesis, and we could not see the details because of corneal clouding. So you can get additional, information at that point. I think we are actually behind time, so I'm going to finish early just to acknowledge, some technicians and technologists that were helping me in Canada with this. We now have a good team at Aga Khan as well, and to thank Sonomed, for some images that I was showing. So again, a technology that is useful in certain instances when you're wondering what is happening to the anterior segment anatomy, the morphology, and you can actually delineate mechanisms of glaucoma that involve the angle or retroiridal space that otherwise would be hard to see just using light technology. Shukriya.
Thank you so much, Professor Karim Damji. I would like to now invite Dr. Mahmood Ali to speak about OCT angiography and its role in glaucoma.
Bismillahirrahmanirrahim. Assalamu alaikum. So I will be discussing role of OCT angio in glaucoma diagnostics and diagnosis. So we are lucky in a manner that we live in an era when we have the facility of so many investigations that help us in the diagnosis of glaucoma. But when we discuss various diagnostic tools, it is important to know their limitations also. And only in this way, we will be able to ensure that we are not over-diagnosing any condition. So there is no doubt that currently there is a lot of dependence on OCT, RNFL, and also ganglion cell complex. So because these investigations give very important information about the structural changes that are occurring in patients of glaucoma, and we can not only, of course, clinical, there is no replacement of the clinical assessment, but after clinical assessment, we can correlate these with visual fields and OCTs. So OCT, RNFL, and ganglion cell complex not only help us to correlate these findings with the structural changes that are occurring, and also we can monitor the patients that are diagnosed as ocular hypertensive patients, and we can get trend reports. For example, this is a trend report of a patient of the past 3 years, and we can see that the patient is stable without any treatment. But as I already mentioned, that every investigation has some limitations. So same is true for OCT, RNFL, and ganglion cell complex, and there are some conditions in which this diagnostic tool does not give us valuable information. Some of the examples are shown here. A patient with myopia and tilted disc, then again a high myop patient, and then in we know that in advanced stages of the disease in glaucoma, there is a floor effect. When the OCT is RNFL readings are not reliable, and we have to shift and or depend more on the visual field 10-2 and 30-2. So of course we need investigations that can complement our clinical findings, and one of these investigations is OCT angio. And OCT angio basically is done with the OCT machine, and it basically what it does is that high resolution imaging. It helps us in getting high resolution imaging of retinal and choroidal and optic disc vasculature. It basically analyzes successive tissue images of the same tissue, and then it captures the changes in the light scattering. So this is one image and then the second image of the same tissue, and then the machine analyzes the changes in the reflectivity, and these changes are detected, and this is basically thought because of the movement of the erythrocytes and the blood vessels. So these are marked as blood vessels. So the question is, we know that there is this investigation is used by our retina specialists in many conditions. Is it also helpful in the diagnosis and monitoring of glaucoma? So we will be briefly discussing this. Of course, it is a lengthy topic. I will just be showing some slides. So studies have shown that one of the most important parameters of OCT angio is the total vascular density as well as the parapapillary vascular density loss or density that can help us to correlate our findings. And studies have shown that both OCT angio as well as OCT are complementing each other in cases of glaucoma, early diagnosis till late stages. So this is patient number 1, and we can see that OCT RNFL of the right eye is showing inferior quadrant thinning of the RNFL, while the OCT RNFL of left eye is normal. Sorry, this is not working, so I will not be showing the pointer on the slides. Now, this is the ganglion cell complex of the same patient, and we can see that there are changes in the ganglion cell complex of right eye, whereas the ganglion cell complex of left eye is normal. And see that the OCT angio of right eye is also showing thinning in the peripapillary vascular density, superficial vascular density in the inferior quadrant in the right eye, whereas the RNFL, OCT angio of the left eye is perfectly normal and the density is more than 50% in all quadrants. This patient was monitored for many weeks or months, and then the next scan of the OCT angio showed some further progression, and we can see that the vascular density has further decreased in the inferior quadrant in the right eye. This is a case of advanced glaucoma in which there is CDR of 0.9 in right side and 0.8 in the left eye, and we can see that there is a decrease in the superficial vascular density in both eyes. This is a case of, again, asymmetric changes. Right eye has a normal RNFL, and we can see that the superficial parapapillary vascular density is normal, whereas on the left side there is decrease in the peripapillary vascular density. This is a patient of ocular hypertension, and see that at the moment, although vascular density seems normal in both eyes, but see that there are some changes in the right side on the readings are less as compared to the left eye, and the same pressure is different in both eyes, and there is some decrease in the percentage of the vascular density on the right side as compared to the left eye, and we are closely monitoring this case. Then the next is that are these changes on the OCT angio, they also correlate with the visual fields or not? So studies are showing that, of course, the vascular density loss also correlates well with the visual field changes, especially in the moderate and the advanced stages. So this is a case in which there is RNFL shows inferior quadrant thinning, and there are superior hemifield decrease in the sensitivity, and we can see that correspondingly there are changes in the superficial vascular density peripapillary. And the next question is that what about the macular microvasculature? Is this also correlating well? So studies show that at the moderate and the advanced stages, these correlate well with the changes. However, there are conflicting reports about the microvasculature changes in the early stages or very advanced stages. So this is a normal ganglion cell complex as well as the OCT angio, and this is a case in which there are changes in the right side while the left eye is normal, and same we can see that the density on the right side is decreased as compared to the left eye. Now, this is the last case that I am showing, and just to highlight that it is not only important to rely on one investigation. We have to do a complete assessment of the patient first clinically, then see various investigation, and then make our diagnosis. So this is a young lady who has, of course, there are visual field defects in the inferior hemifield, and superficial vascular density is also decreased, peripapillary vascular density is increased in the corresponding areas superiorly. And see that there are also changes in the macular thickness, ganglion cell complex, superior hemisphere, and vascular density is also decreasing. However, macular density is almost in the normal range. And this is the trend report of the same patient. So I have been monitoring this patient for the past 3 years, despite of having a normal visual field and OCT changes, having visual field changes as well as thinning in the RNFL OCT and also changes in OCT angio, but the patient still has a normal trend report, and the intraocular pressures are 18 and 19, and I am closely monitoring that case. So in conclusion, I will say that, of course, OCT angio is complementing the other investigations, especially OCT, RNFL, and ganglion cell complex, and it is helping us in monitoring the cases. There are some challenges with this investigation, as is the case with any investigation. So the challenges are currently most of the studies are cross-sectional, so we need longitudinal studies for this investigation. What is the relationship between the vascular changes and the structural changes? Are these the vascular changes that are occurring first, leading to the damage of the ganglion cells, or it is the reverse, that the ganglion cells are suffering deaths or apoptosis, and this leads to decreased metabolic demand and vascular loss? And of course, technological advances will help us to further improve this investigation and utility in future. Thank you very much. Thank you very much.
Thank you, Professor Dr. Mahmood Ali. I would now like to invite Dr. Sidra Riaz to speak about RNFL analysis in glaucoma. We are happy to take questions as we finish the sessions. We might be here for 5-10 minutes extra if we have to answer the questions, but we want to finish the session in time.
Akhtar Said Medical College, and I will discuss the role of OCT in glaucoma. OCT is one of the excellent tool if media is clear for all the patients for which they have suspicion of glaucoma. Someone has very rightly said that if you can diagnose the glaucoma earlier, you can treat it earlier. If you treat it earlier, that you can slow down the progression. And if you slow down the progression, you can prevent blindness. The definition of glaucoma is have been going more and more complicated over the years. In 1960, it was the one thing which was associated with glaucoma was raised IOP. Even if you ask our medical students about anything about glaucoma, the first thing they will tell you is raised IOP. But now the definition has been slightly modified from 1960 to at present, after 2020, that previously it was raised IOP, optic nerve changes, and visual field defects. But at present, it is chronic progressive disease with optic nerve head changes with specific visual field defects, and there is a gradual decrease in ganglion cell density. And IOP, rise in IOP may or may not be associated with glaucoma. So in order to detect early, OCT is an excellent tool. How it works, that it not only early detects the glaucoma early or any glaucomatous change, but we can also monitor the progression of disease if we have the initial OCT. But as it is slightly expensive investigation, so every patient is not a candidate for OCT. These are excellent for those patients in which you suspect that they may be a case of glaucoma and there is no visual decreased vision is noted at that time. So OCT will pick up those patients who are in pre-perimetric glaucoma from those who have not developed visual field defects at, at the time of presentation. So initially when there is increased loss of ganglion cell complex and IOP rise may or may not be present, at this stage in the right half of this curve, you can pick up the disease from this with the help of this OCT. There is gradual modification in machines from 1990 at present, and software is being developed with more progression in this technique of OCT. Benefit of OCT is that the media clarity is mandatory for OCT. It is non-invasive. Even some of the machines they say that even pupillary dilatation is not even required, but every patient for glaucoma, retinal, RNFL should be dilated. It is non-invasive, non-contact, high-resolution technique which produce quantitative results, and it is very analogous to B-scan. Why OCT? Because 30 to 45% of retinal ganglion cell loss is required to produce a demonstrable visual field effects. SWAB, that short wavelength automated perimetry, can detect this early visual field effect, but OCT can do it before that. So the pre-perimetric glaucoma detection can be very helpful with the use of this OCT. Here in this graph, you see that these are retinal nerve fiber layers, which is first to be decreased in patients of glaucoma, followed by disc morphological changes, and then comes the visual field. So it is the green line of this graph, which you will pick up with the help of this OCT. The role of OCT is that when you test a patient for glaucoma, the three things you must see in that patient is: number one, the optic nerve head changes; number two, retinal nerve fiber layer thickness; and then ganglion cell complex. The optic nerve head changes, the prescription of cup disc ratio, although it varies from doctor to doctor, but if you document this with the help of OCT and you have a colored photograph of this disc, it will help us to see any progression. In this retinal nerve fiber thickness, you enter the data and you must be very accurate with the age of that patient, because it is a age match control normative data with which we are comparing the patient. The red colors, you all know that they show the thinning, the danger area, because it is the deviation below present in less than 0.05%. Green is the normal and yellow is the borderline. The thickness of superior and inferior retinal nerve fiber thickness is important, because the initial thickness changes are seen on the superior or inferior quadrant. Here you can see in the upper half that the butterfly shape or hourglass appearance of both right and left disc, they are shown. Not only shown, but also a table which is showing the rim area, retinal nerve fiber symmetry, average cup disc ratio in both eyes. So, and on periphery, there is a B-scan, and in the middle, you can see right and left retinal nerve fiber layer thickness. And here the map also shows the borderline area, the red area, and the normal area. Why we are interested to do OCT macular area? Because it is an ideal region, because more than 50% of ganglion cells, they are present at the area of macula. So ganglions, we are here, ganglion cell complex term is used because we are not only measuring this ganglion cell thickness, but it will measure number one, internal plexiform layer, ganglion cell thickness itself, and retinal nerve fiber layer thickness. So it is combinedly these 1, 2, 3, they are known as ganglion cell complex. In this area, the hot colors and blue areas, you can see, even the map shows when you get the print of this ganglion cell complex, you can easily detect that the density is bit in greener color or denser in normal thickness map, and in glaucoma patients, there are more red and yellow colors. So for OCT, number one, we must remember that every patient is not a candidate for OCT, but all those patients in which you suspect that they may be a case of glaucoma on the basis of your clinical examination, they must be sent for OCT. Number two, if you do OCT but you do not enter the correct age of patient, then this OCT printout would not be reliable. And number three, RFL evaluation is important, not only for diagnosis, but also for monitoring of glaucoma. It is more sensitive than only measuring of cup disc ratio, and it should always be interpreted with age, your image quality, which will depend on media clarity, and scan location. The circle we see around the disc, it must be having the disc in the center. And if there is slightly dislocation of this center, the result may be prejudiced. Thank you.
Thank you so much, Dr. Sidra. Now we are up to the last presenter. Dr. Rashid Zia came all the way from Kent, UK, and he's going to talk about OCT in myopic, tilted, and anomalous discs, which is always a challenging thing, and overdiagnosed glaucoma wrongly most of the time.
Assalamu alaikum. Thank you very much, Professor Imtiaz Saab, Professor Meher Saab, and Professor Damji for extending, and Nadeem Saab for extending invitation. I have only 10 minutes, and presentation is slightly longer, but I'll try to finish it quickly. So without wasting any further time, the presentation is on the structural changes in disc and retina observed in glaucoma with increasing frequency as compared to the non-glaucomatous eyes. So I will be discussing these 5 issues: hypodense holes, PERDs, and paravascular defects, peripapillary retinoschisis, and internuclear layer pseudocyst. I'll come to all these things in a time. They seem to be heavy names, but the case I would like to make is that all these 5 signs are actually belong to the same family, which you may pick up on OCT scans. But before I proceed, I would like to share this very interesting photograph called The Blind Man and the Elephant. And if you look at the blind person looking at the tusks of the elephant, he would say elephant looks like a spear. A blind person who looks at the tail will say the elephant looks like a rope, and so on and so forth. But the point is that even if they disagree with each other, they all bring useful information to a bigger picture. So no one signal sign is important. We all collate them, collage them to come to a real-term diagnosis. And also, the eye does not see the mind, which the mind does not know. So what my purpose of this presentation is to educate so that I can start seeing those subtle signs of glaucoma. But before I proceed, there is no method which is fully validated and for the clinical use, and a good performance in a study does not guarantee a good performance in the clinic. So all of this story started with hypodense holes in nerve fiber layer. So this is a circumpapillary scan of the optic nerve head and possibly the most useful scan in the glaucoma. And you can see different types of low reflectivity areas, and all of these eyes are without epiretinal membranes and VMA. So you can see low reflectivity areas, but if you look closely, there's no nerve fiber layer left in that area, but the nerve fiber layer thickness is still within the normal bounds. So those people who depend on the traffic lights of the OCT, they may be mistaken, but whereas this person has significantly advanced glaucoma. So, and then Zin et al. In 2011, they look at 208 eyes of 110 patients with 45 controls, and what they found that in 25% of patients, they found hypodense holes. And when they plotted the position of the hypodense hole, they found that it's in the inferotemporal and supratemporal areas. So this is a scan, and this is 1.7, 1.2, this is 1.4. So every time they see a hypodense hole, for example, at 1.2, they will draw the position, they will look at the blue, green, and red at different millimeters away from the disc, and they will draw the hypodense holes. And you can see the way the hypodense holes, they appear in the nerve fiber layer, that's in the arcuate fashion. And this arcuate fashion is very diagnostic of the glaucoma. But very interestingly, none of these things were found in the control. So a hypodense hole has some value to it, and if you see those, please be careful. So this is one of my clinic scans. So I saw this hypodense hole, and then so I used the marker. The marker came up to be here, and you can see the nerve fiber layer defect there, nerve fiber layer defect there, and some color mismatching there too. So, and then we come to the next one, which is called paravascular inner retinal defect, or PIRD. So this paper was not about glaucoma. So this paper was it all started from this. This wasn't about glaucoma. This was about the epiretinal membrane and high myopia patients, where the researchers, they found paravascular defects along the blood vessels. And now we know that glaucoma is more common in patients with epiretinal membrane, and we all know it's fairly common in high myopia anyway. So what happened was when they, this is, at this slice, you can see the paravascular defect looks like this. At position C, it looks like this. At other positions, it looked like this. So the point I want to make is that the paravascular defects, the PIRDs, they can be of many different shapes and sizes. So, but once that was done, that was nothing to do with the, so this is again the same things. You can see the paravascular defects radiating out along the blood vessels, and you can see these defects of different shapes and sizes. But once it was done, that was it. People forgot about PIRD in glaucoma patient. And then Hood et al. Now, Hood is a very prestigious name, and most of your OCT scan machines has Hood analysis in it. And nowadays, we don't really proceed without Hood analysis in glaucoma patients. So what he did, he went back to the same study. He contacted the same researchers and said, let's look at your eyes again. And then he studied 19 eyes of 15 glaucoma patients, of the same patients. And the red dots are glaucoma only. So you can see, and then you have patients with epiretinal membrane and patients with high myopia or combination. So you can see, so they found patients where PIRD was in an arcuate fashion, but only in glaucoma patients. It wasn't, so it was present also in high myopes and epiretinal membrane patients, but it was also present only purely in glaucoma patients. So that was number two. First was the hypodense holes, and then it was PIRD. And then this is the very important, I will make a case that all these things are related to each other. Peripapillary retinoschisis. Now this is a very, very important thing, because if you see peripapillary retinoschisis, it's not only present in advanced glaucoma, but it's also present in fastly progressing glaucomas. So, so you can see above the ganglion cell layer, there is a splitting of the peripapillary tissue. And you can see here in 2010, you can see the peripapillary retinoschisis. And in 2013, if you compare this, this is a lot smaller. So one of the other characteristics is that this peripapillary schisis comes and goes. So at one time, it may be very thick. At other times, it will be very thin. And if you do not pay attention to these, I've seen patients going blind in 4 or 5 months and others going blind in 4 or 5 years. But mostly patients are blind within 3 to 4 years with peripapillary retinoschisis. And this is not that infrequent. You will find it in about 6 to 7% of patients. So this is an example. So in 2010, you can see changes coming up as the time passes by. Please forget about the red dot. And it comes and goes. I can't see it clearly from here, but you can see by the time the last slide comes, the nerve fiber layer is completely gone. Initially, the nerve fiber layer on OCT scan may be thicker. Due to retinoschisis, it will appear thick, and the OCT scan will say it's all green. But if you do not look at the circumpapillary scan, you will be mistaken, and you will miss glaucoma. So, but if you do progression analysis, you will see that it comes and goes of different various. And by the end, when you realize that something is wrong, it's already too late and the nerve fiber layer is gone. So this is again, you can see this is right and left eye, so you can see how the thing changes. By the end of the nerve fiber layer is already gone. So this is from my own clinic. So you can see in 2018, none. In 2021, at the same spot, I found this. And after that, I had to do a trab very quickly because he started to progress very fast. So this is the peripapillary retinoschisis. Now we come to the disc schisis. So when the lamina, this is the brighter area is the lamina. When the lamina sinks due to glaucoma, the nerve fiber layer, the neurons are stretched. Now these neurons are contiguous with the peripapillary tissue, but they're also contiguous with the lamina. So when the lamina sinks, the nerves cannot slide in and out, so they're pulled. So when they are pulled, they're stretched, and this stretching can lead to schisis in the prelaminar tissue, which is actually the same as the peripapillary schisis. So in many peripapillary schisis patients, you may also find disc schisis, or you may just find disc schisis and no peripapillary schisis. So this is again one of the important things. This is again important, and you can see over here microcystic changes in the inner nuclear layer. The important thing is that this is also found in advanced glaucoma. So you can see over this portion, the nerve fiber layer is almost all gone. So if you're looking at the retinal thickness or ganglion cell layer thickness, you can be easily mistaken by the green colors. But if you look closely, you can see the cyst. And this is because as the neurons, they go away, the Muller cells, they have a spring-like action, they expand. Previously, it was thought that this may be due to the demyelinating diseases, but now all of us know that demyelinated tissue does not lead to microcystic changes there. It's actually the loss of the neural tissue, and the Muller cells, they then just spring up. So this is again a very interesting sign that you can see that if you look at the disc margin and then look at the first bifurcation of the blood vessels, as the glaucoma progresses, as the lamina sinks, then you can see the blood vessels may actually be dragged towards the disc margin. And this is quite useful in very, very tilted, anomalous, hyperplastic nerves where you can't really see what's happening. And if you see the blood vessels dragging towards a disc margin, you can understand that the disc is failing. So this is again from one of my, I don't know whether it will run or not, yeah. So this is the lamina. This is the lamina. So you have to follow, if you follow the scan, you will see that at one point the lamina goes away. Can you see the lamina becomes bent? I don't know whether you can appreciate or not. There are spaces in the lamina which are not present in the other scan, and the lamina appears bent. So this is laminar cupping. Cupping is of two types, prelaminar cupping and a laminar cupping. So this is a laminar cupping, which is very, very suggestive of pressure-related defects. So if you have this kind of change at pressures of 12 or 10, then you need to do TRAB. Neuroprotection may not be that important. So I'll finish by conclusion that all of these things, the inner nuclear layer defects, the cyst, the PERD, the peripolychitis, they're all related to the same family. They're actually the same thing, but they may appear differently on different scans. And they are all due to the mechanical shearing and the mechanical properties of the retina. And peripapillary retinoschisis is associated with fastly progressive glaucoma, and inner nuclear layer cyst is associated with advanced glaucoma. But whenever you see hypodense holes, etc., then it's important to be more vigilant about the glaucoma progression. Thank you very much. I hope I finished on time.
Thank you so much, Dr. Rashid. So we'll take the questions quickly. We don't have much time. We are already over the time for session allocation, but as glaucoma is such an interesting thing, you can compromise 10 minutes of your lunch for this. I would like to ask Professor Damji if he's got any questions.
The peripapillary retinoschisis, or schisis, or schisis, or however you pronounce it, but is that an artifact that is created on the OCT? So you're not really mapping the thickness properly because of this, increase, and then maybe it's masking the thinning or and in that case, is visual fields, are they more helpful to show the loss as well?
Yes, exactly. So this is actually the neural loss. And as the nerves are lost, then the supporting tissues, they behave very differently. They can swell up, and that's why it may appear thickened. So if it appears thickened, the segmentation of the layers will say that this is a healthy nerve fiber layer. But the important point is that in there you are losing the nerve fiber layers. And yes, they are associated with visual field loss, with a rapidly progressing visual field loss.
Any questions from the audience, please? It is exactly the
you
same
mean
question.
You mean anterior segment OCT?
Yes.
Right,
Anterior segment OCT.
So the anterior segment OCT will show some of the information in the angle, for example, if you're looking at some angle changes or the plateau configuration, etc., from an anterior iris perspective, but it won't show what is behind, in the deeper layers. So I think the real value is two things. One is the retroiridal space, like behind the iris, the ciliary body or deeper layers of iris. And the other is if you have a cloudy cornea and you cannot visualize properly the angle either by gonioscopy or anterior segment OCT, then it allows you better, sonographic like visualization. So it is more time consuming, and therefore it's not suggested for everybody just once in a while if you have a challenging case, So some of the cases I showed had cloudy corneas and things like that because we could not really see what was going on. Even the granulomatous AC reaction in the phacolytic or phacoantigenic, we could not appreciate it fully because of the cloudy cornea, but then the imaging technology just shows it beautifully,
Assalamu alaikum. This question is to Dr. Mehnaz and Dr. Mehsood. I'm sorry, I don't remember the full name. About the corneal thickness and the corneal hysteresis. We know that both these parameters are low in patients of keratoconus, and once we do the refractive surgery. So, although I heard something which I couldn't get, that there is a strong correlation of corneal hysteresis, glaucoma, and post-refractive surgery patients, but I would like to hear more, because this creates a confusion to me that I see a patient with low corneal hysteresis and low CCT, which is acquired. So how do I correlate it with this finding that the low CCT is a risk factor for development of glaucoma? And similarly, low corneal hysteresis is a very important, as I saw the presentation, is a very important risk factor for glaucoma. So do I perceive that patients of keratoconus or acquired lower CCT also will be those patients who will be at increased risk of glaucoma, number one? And number two, are there other devices for measuring corneal hysteresis other than Aura-G, like we have Corvus ST available in Lahore, where I practice. That's why I'm asking that whether it can help me get corneal hysteresis.
Yeah, that's great. If
Thank you very much for your question. So I think as far as looking at keratoconus or looking at situations where, let's say, a patient is post-PKP or has had a corneal or any other corneal pathology, post-LASIK particularly, corneal hysteresis is not, you're not only looking at corneal hysteresis because you're looking just at the biomechanical properties of the cornea, so you will get an intraocular pressure which is corneal compensated, looking at how you've actually changed the biomechanics of the eye. Post-LASIK, you've changed the biomechanics of the cornea. It's also changed in keratoconus. It's also changed in situations where there's been some other pathology in the cornea. So that's where, if you look at the value, you're not looking at the corneal hysteresis value. You're looking at the corneal compensated value of intraocular pressure, right? Which is the value, the first value that's given to you. So you get a Goldman value and you get a corneal corrected or corneal compensated value, and then you have the corneal hysteresis value. So that's what you're looking at in the post-refractive patients, PKP patients, keratoconus patients. As far as looking in terms of, when you have a corneal thickness decrease is an independent risk factor. What the difference there with corneal hysteresis is it's a little bit more accurate. So when you look at corneal hysteresis, sometimes you can find that the corneal hysteresis is lower in a patient with even a high corneal thickness. Right? It doesn't go exactly hand in hand. So it's more complex. Very often in individuals who have primary open-angle glaucoma, normal tension glaucoma, or pseudoexfoliative glaucoma, you will see lower corneal hysteresis, especially in the higher progressives. But it can also be decoupled one from the other. And I think was there another question that you had? About the Corvus? So the Corvus does not calculates a different value. To my mind and to my knowledge, the Aura is the device that is used for corneal hysteresis values directly and giving you a corneal compensated value from there.
Sorry, Dr. Manaz, if you just stay, I want to ask you one question. I've noticed an issue with repeatability of Aura, and I think that could be because of the patient factors. So can you identify any patient factors that can affect the repeatability of Aura figures?
So the repeatability of Aura, so if you look at a waveform score on the printout and on the machine itself, it will give you a waveform score, which is again like 0 to 10. If you get a low waveform score, it's almost like doing a poor OCT. So you must always look at the waveform score, and if it's higher than that, it's actually a really good reproducible. But if you find that your waveform score is lower, you'll need to just redo the scan until you get to a higher waveform value. It can be done right away. But the waveform is very important, and I think that's a really important question. It's just like looking at a poor signal strength for an OCT. Won't give you the right result.
So in that example, do you ask the technicians to just check the quality?
Yes.
And repeat if necessary?
Absolutely.
Or if the eye is dry or there's some other problem, you can repeat it next
just
time?
have them blink. Sometimes they're squeezing, they're not positioned correctly.
Squeezing, yeah.
But it's the technicians can very easily identify. They can be told, below this is not acceptable waveform for me. And if they continue to repeat it and you still continue to get a poor waveform, then I have that in my mind that this may not be really a value that I can count on.
Thank you.
Can I contribute?
Please go ahead, Dr. Rashid.
So when we measure pressures, there are two terms that we need to look at. One is the accuracy and other is the precision. Accuracy is how accurate we are measuring the intraocular pressure. And when we look at Aura, Aura is a fast loading technique. GAT or the Goldman is a slow loading technique. So there is no tonometer in the world which will look at both viscoelastic properties of a fast loading and a slow loading. So that's why there's no accurate tonometer in the world. But why GAT is still the precision, why GAT is still the gold standard, that's because of its precision. Because inter-observer and intra-observer variability of GAT is lesser than the Aura. Aura is an amazing technology. And I think all glaucoma clinics where we deal with the advanced patients, this is very important. I practically only use it patients where I'm actually confused what I'm dealing with, and also in LASIK patients. Because with LASIK, the corneal edema, it depends on how much corneal edema is there. A little bit of corneal edema may lead to a different corneal hysteresis, and a large amount of corneal edema may actually make it very soft. So, and in those cases, you can get very wild readings and no precision with or accuracy with anything. So in those cases, aura is very, very useful. But for all practical reasons, the precision or the repeatability of GAT still takes the precedence over.
And I agree with you. And that's why for my own patients, I always do a GAT. And in those patients where I need to make a clinical decision, I will do an aura.
Yep.
But I completely do agree with you. So
But
I don't
if
think
you-
that we should be using the aura as a technology to substitute our Goldman tonometry. I certainly don't think that that's a good idea. I do know of some clinics in the United States that are using it, but I think it's still more almost like a screening within a glaucoma clinic.
I fully agree, and this is why we had a huge argument in UK EGS this time, because somehow some of the very, very top minds in the world, they were advocating aura. But when you look at the precision, and the World Glaucoma consensus is very clear about that, that aura precision is not as good.
Absolutely, and I think it should be used for hysteresis and not just as a substitute for an air puff tonometry.
Thank you so much. We've got just time for maybe one short question if anyone's got any. So yeah, so I guess everyone's hungry now. So thank you so much everyone, all the presenters for nice, lovely, insightful presentations. And I would like to conclude the session now. Thank you for chair and co-chair for being here. Thank you.